Now that we've gotten that all taken care of and we've rebuilt that PAPR, Allison, can you show us how to keep track of those canisters? Because we don't want to overuse them. We don't want to get to the point where it plugs up while we're trying to breathe with it.
I don't know one nurse that doesn't enter every single shift and go in and check all the labels and all of the open containers to see when was that can of wipes open, when was that saline bottle open. They've got dates, they've got times, and that's always been part of our labors of love to make sure that all of those things stay appropriately dated and timed. We want to do the same thing with these reusables layers, just so that we have that same protection for these over time. You can use whatever system makes sense to you and your colleagues, but I tend to just treat it like a bottle of sterile saline, and it's just going to get, Monday, Tuesday, Wednesday, on whatever day that was changed, so that I know that if I come to work the next day, maybe my PAPR got mixed up with somebody else's. I'm going to check this. Does it still have Monday on it and today is Wednesday? Guess what? I'm taking it out. I'm getting out my marker. I'm drawing my little cutouts, and I'm going to fix this before I put it on my face. And I always remember, too, when rebuilding the PAPRs, 8s. 8 layers, and you'll probably get 8 uses out it before it stops sucking air when you hook up the battery.
So do you see an end to this deadly pandemic anytime soon?
The pandemic will end, and that, I think, is a very important message that people need to hear, because we have to have a feeling of security and control in our lives, and knowing that there is an end provides that. Just like masks, cloth masks for the general public, help provide a level of emotional, behavioral health security, in addition to any viral protection they may or may not actually provide. I'd mentioned earlier something called the Reeves curve, named after Jim Papa Reeves, who was a virologist who characterized the math for a pandemic and many of the factors that change whether or not a virus expands wildly in the population, or whether we flatten the curve. And I mentioned earlier social distancing. If 80% of everybody in the nation stays home for 4 weeks, on week 5, we're done. The problem is, if we're at 50%, it could take 12 weeks to reach peak. And we're only in week 4 at this point. When we're somewhere between 50 and 80% stay home, that is the difference between 12 weeks to peak and 4 weeks. That's why they're seeing a blunting of the peak in New York. People are finally in the city starting to get the hint, and they're pushing 60, 70% stay at home. In some communities, they've met 80%. As other large cities have more problems, you'll see more people stay home. You'll see the peaks blunt. How long will the nation deal with this? Estimates are right now somewhere between late April and early June before the virus is just a background infection and it's no longer leading the news, because it's no longer causing large peaks, large death rates, large infection rates, and healthcare overwhelm. But it really is in the hands of the people, not on this side of the camera, but on that side of the camera. If you stay home, if you make sure that your family stays home, then this will burn down sooner. The virus will burn out in the population rather than the population burning down because of the virus.
So the question is, what is an N99 mask?
That's a great question. A lot of people hear these numbers, N99, N95, N70. And they think, well, that means that it gives me 99% protection or 95. And that's almost right. What it really looks at is how many hours can you be in an environment, and how many hours would it be equivalent if you weren't wearing a mask. What does that mean? An N95 mask. If you are working in a COVID environment, like a healthcare worker in an emergency room, for 100 hours and wearing an N95 mask, then it's the equivalent of only working 5 hours with no mask. If it's an N99 mask, then it's the equivalent of only working 1 hour without a mask. The reason we look at it from that perspective is that we look at how you catch a virus based on how much you're exposed to. How much virus for how long, dose and time. And an N95 mask allows you to have far less time at the same exposure. So you get the equivalent of less time. You can work longer. When we work with powered respirators, we work with higher degrees of filtration. A brand new canister can have an N99.9, where you could literally work for 1,000 hours and have less than 1 hour's exposure to the virus. Some of you might have noticed if you buy particularly N99 masks that there's a little purge valve on the front that when you breathe out it opens up and it lets the air out. Now that's in order to keep the mask from popping away from your face when you breathe out or when you sneeze or when you cough. It also means that that mask does not protect the people around you because every time that valve opens you're breathing unfiltered air in a nice tight stream at some distance in front of your face. What it does do is it tries to protect you, again, to that N99 or 99 hours of exposure equals 1 hour without a mask kind of protection. And that's great for you. And this gets to that question, who does what kind of mask protect? Different masks are designed to protect different ways. You've seen those orange duckbill N95 masks that healthcare workers wear. They're designed to protect both the healthcare worker and the people that the healthcare worker is taking care of. It's a two-way protection, but it has no escape valve, and it has to be properly fitted. I can't wear a mask because of the beard. As soon as the beard touches that mask, the edge of the mask gets wet, it gets separated from my face, and my N95 mask is little better than N50 at that point.
Dr. Ramirez, what happened to the ventilators in New York?
Another great question. Like any other medical device, ventilators require regular routine maintenance. And they have safety, many of them have safety devices that will shut them off if that maintenance has not occurred. Now, if I use a ventilator on a patient in the emergency room and that patient comes off the ventilator because they get better, you certainly want that ventilator cleaned and serviced before it becomes your ventilator. You don't want me blowing whatever was in the other person's lungs into yours. That's the reason for those protections. We also want a ventilator that's been stored for a period of time to be checked by a professional, either a respiratory therapist or a biomedical engineer. Somebody who knows how to make sure that that ventilator works and will continue to work without monitoring 24 hours a day because it's breathing for somebody who cannot breathe for themselves. When these devices are stored in the national stockpile, they're not taken off the shelf every 90 days or every 6 months for maintenance. They're stored in a fashion that allows them to be stored long-term without deterioration. But that means that you now have to take them out of storage and bring them back into service. And that requires a biomedical engineer. And unfortunately, that message was lost along the noise as those ventilators moved from the national stockpile to the state of New York. Fortunately for the state of New York, they had some great engineers who volunteered their time and their effort. They educated themselves on how to work with these ventilators. They sought the expertise that was required, and they learned to bring these ventilators online in about 30 minutes, which is about the amount of time it takes to redo them. And I have nothing but kudos and bravo Zulu for those wonderful engineers who came out and took care of that problem. But this is one of those issues that you have to deal with when you store medical equipment. You have to bring it back to service.
What medication regimen would you recommend for COVID-19?
That one is a tough question because I think that it's foolish for any small organization like ours, even one that has read the majority of the scientific published literature to date, as ours has, to make a singular recommendation for medication. As a clinician, I can tell you that choosing medication is a very complex set of decisions that can't be substituted by a computer. It is something that we call the smart docs scale. You have to be a smart doctor, a smart nurse practitioner who is taking a look at this patient and choosing the best medications. Now, there are some rules that we have learned from the literature. One is that you have to be using multiple medications from different classes of drugs so that you attack the virus at multiple places in its life cycle, so that you can stop the virus from replicating and you can decrease or eliminate contagion. The question then becomes, which drugs? There are many that are in trial. The Chinese had fantastic results with combinations of Arbidol and certain HIV drugs called protease inhibitors, plus, yes, hydroxychloroquine. But hydroxychloroquine was only one part of a complex cocktail that stopped the virus in its tracks in individual but severely ill hosts. If it were my family member, and Arbidol is not a US licensed drug, but you can buy it and have it shipped here. If it were my family member, I would give them Arbidol and hydroxychloroquine and a protease inhibitor. But that's me as a personal physician, not a recommendation for the general community. Remdesivir is in clinical trials now, a Gilead company drug, and in combinations, it has also been shown to be effective overseas. We'll see how the US trials come out. Those results should be available within the next few weeks. There are trials that are looking at combinations that include malaria drugs, antibiotics, flu drugs, and HIV drugs. And that combination, again, was successful overseas. It was very successful, in fact, for the Italians when they finally got that cocktail honed in. Will it be successful here in the United States? Has the virus mutated too much for that to work? We don't know yet. And that's the problem with clinical trials. That's why it was so important to establish that objective performance criteria that I mentioned earlier, so that we have something to compare each of these new regimens against. So the question of race is coming to the fore now as we're seeing larger degrees of infections in the United States. And race is an easy demographic to point to when you deal with infection, but it's far more complicated than just race, because we are also seeing that those in low socioeconomic group, independent of race, are having higher degrees of infection and higher degrees of death than we're seeing in those with high socioeconomic status. Some would say that's because of insurance or because you have access to therapy. But the reality is that we don't know what therapy works. So that's not a factor anymore. And I will tell you, it's never been a factor in the emergency department. We see everybody and we treat you based on how sick you are, not who came first, and absolutely don't care who's got a gold card in their wallet. The problem with looking at race is that we have to look at other factors. And Allison is really the expert on these in our organization. It's something called social determinants of health. Those things other than what you do personally for your own health that impact how your health turns out.
The World Health Organization has been at the forefront of this type of research, social determinants of health. What are the aspects of the environment, the air quality, the water quality, noise pollution that are affecting your everyday health, and how those things change in urban versus suburban versus rural. How do those change in one culture versus another? What is the impact of those things? What is the priority in any neighborhood, no matter where it is on the planet, of clean air, clean water, and free from noise pollution? And what's the ability to combat those if they are already there, pre-existing in your neighborhood?
And you have to realize that on top of what the environment does, you have to look at how close are people living together. Lower socioeconomic groups tend to live in tighter communities in the urban environment. So social distancing is almost unheard of. Because sure, you can social distance in your apartment from the guy in the one-bedroom apartment next to you until you walk into the hall that's only 30 inches wide, until you get into the elevator that's only 4 feet across. And neither is well ventilated. You also have to look at what kind of jobs do they do. as a healthcare worker, I don't have a stay-at-home job. But the majority of people in the higher socioeconomic groups have either a stay-at-home job or a non-essential job. So when stay-at-home orders happen, they stay at home. People who are blue-collar, who are in the lower socioeconomic groups, they don't have that luxury. Many of them work in essential jobs, so a stay-at-home order doesn't apply to them to begin with. But even if it did, the jobs that they have don't let them work from home. And if the job isn't eliminated, if it isn't closed, then they have to go into work and work in whatever environment that is, which very often does not allow for good social distancing.
We're currently faced with a lot of jobs that heretofore were not considered stay-at-home jobs, or whose employers might not have recognized that potential that someone could have that as a stay-at-home job. But certainly, as you're mentioning, ones that will never be able to be that. You're not going to be a police officer who can have who's going to be able to do that job, do the patrol beat from home. You're not going to be able to put out fires as a firefighter from home. You're not going to be able to be a first responder working in an ambulance from home. You may have some support network of staff that can do that, but that's just not going to be the reality. Again, we have folks working in grocery stores and in packaging houses all over the country and in international shipping warehouses. Those are jobs that are essential right now, and those are not ones that you're going to be able to do from home. You may have folks that are working from the ordering and processing and billing that can do those jobs from home, but that's a different story.
Now, the guy who loads the truck has to be at the truck, and he's going to be next to other guys and ladies who are loading the truck and moving the packages. Unfortunately, that's something that disproportionately impacts the lower socioeconomic groups.